get you guys through the process of identifying the murmurs and then treating them. We're going to take it to the next level. The one interesting thing that's really kind of interesting about murmurs, and the reason why we care about them, is that most of them all turn into heart failure if you don't do something about them. And so our job is to prevent that. That's what we're trying to do. Stop the heart failure. So we got to formulate plans and figure out what diagnostic studies. We're going to apply everything we learned from block 1, and we're going to put it in block 2. Okay. And everything is centered around heart failure, whether it's a conduction issue causing heart failure itself, what is the cause? So lots of things can do it. And we're going to go through today and focus in on the tasks that are associated with these murmurs. Okay, so key thing to remind yourself is physical exam. Very sensitive and very specific for picking up heart murmurs. So you have to know that right-sided murmurs, most of them increase with inspiration. Few exceptions, we'll go over those. Most left-sided murmurs are increased with expiration. Preload is increased by raising the legs, like you guys learned in block 1, and squatting. Those increase preload, okay? Decrease preload with Valsalva and standing, okay? And you increase afterload with hand grip. And when you squeeze that hand grip, that makes the aortic pressure higher. The left ventricle has to overcome that. So that increases the afterload, which then changes regurgitant murmurs, makes them louder, and stenotic murmurs get quieter. And then you can use amyl nitrate, which is not very often used, but can be used to help distinguish, especially in patients where there's a question about HOCM. We can use it here. So those are some examples. One of the things that I would point to you to think about is kind of think through those murmurs as we go into some ideas. So first question, check on learning. Which of those maneuvers, right off the bat, can increase the intensity of a murmur of mitral valve regurgitation? So think through this. Which one of these can increase the murmur of mitral valve regurgitation? Not prolapse, but mitral valve regurgitation. Think through that. What's going to cause that regurgitant murmur to get louder? What's going to make more blood in the heart? What's going to keep more blood in it, make it more prominent? Think through that, and kind of as you go through that question, that'll help you pull it out. Okay, good. So as you guys are thinking through that piece of it, you're on the right track. Okay, all right, good. So most of you picked out the right answer on this. Excellent. So you're correct. Right off the bat, majority of you saw hand grip is going to do that, right? You do a hand grip, that's going to force more blood in the heart, and it's going to cause it to back up. And let's see why. Let's see why this is the case. So transient arterial occlusion can also do this. So that's important. So your mitral regurg can go up if you're having Prinzmetal angina. That's an example of those things, okay? So you guys got those components. All right, good. All right, is phenylephrine not often? Yeah, it's not used very often. OT Anders, pretty unlikely. So the answer to this, why it gets louder, is aortic and mitral regurg both are worsening or louder with hand grip, okay? Why? Because more blood comes back into the heart. So I put pressure here. Imagine the pressure. I'm increasing the pressure here, okay? So I force blood back in, which then if I have mitral regurg, it comes up this way. If it's aortic regurg, right, and it's going to swish, it's going to go up and down, and the pressure of hand grip is going to force it back in against that left wall. So the idea is that it's the same rule that applies to VSDs. More blood circulating in the heart is going to increase those murmurs, okay? You just have to, what you have to do is it wouldn't get louder with squatting. No, because the heart gets bigger with squatting, but it's a regurgitant murmur. So the blood flow won't change. The volume of blood in that heart's process won't be loud enough to change it. So certain maneuvers, you can't always just apply, hey, it gets bigger or it makes it smaller. It doesn't always work. So you have to know some of these exceptions. This is an exception. Okay. All right, so let's go into the idea of figuring out mitral stenosis, mitral regurg, and mitral valve prolapse. That's our job today. We're going to start with our stenotic lesions. So stenosis, it's predominant in females, younger age typically where we see it, usually in the second or third decades after rheumatic fever. Okay, get rheumatic fever, and that's the case. Yeah. Okay. So going back to Harris, I explained to you there's exceptions where you can't apply all those rules. So that's the exception you need to know. All right, so most common cause of mitral stenosis is rheumatic fever. That's the most common. That's the one you need to pay attention to. Congenital causes are pretty rare, but they do occur. And it's also rare to get calcification, which can be due to atherosclerosis later in life. That can happen. And then there's this thing called a left atrial myxoma that you do need to know about because it's the most common benign tumor. It's usually in an older patient. They typically have significant weight loss, usually 20 pounds pretty quickly. And on physical exam, they've got a tumor plop. And I'm going to demonstrate that in a second on the next slide that shows what this patient looks like. And these patients typically, when they lean forward and over, the murmur gets louder and it moves because you got a polyp in there. And I'll explain that in a second. Inflammation produces the rheumatic mitral stenosis that we saw. And then you can get calcification due to many causes, atherosclerosis being one of them, and aging. Okay, so this is that polyp. So you have an atrial myxoma. It's the most common. It's on a pedunculated stalk. Here's that stalk. And so this sets in the left atrium. It's benign until it's not benign. And then it starts blocking it mimics a mitral stenosis. So it mimics it at the mitral valve, and it causes significant weight loss because you're blocking, the heart has to work harder around this, and you're blocking blood flow. And you get this tumor plop it's worse when you lean forward. What does that really mean? And so when you lean forward, you hear this movement to where you have a diastolic rumble movement between two different locations, and it plops. It goes boom, boom. You'll hear it twice. And so the classic presentation is older lady, weight loss, and then you hear this tumor plop that sounds like mitral stenosis without an opening snap. Worse when that patient leans forward. Okay, so let's do a check on learning. You've got a 65-year-old female that presents with no prior past medical history to the primary care physician with increased dyspnea on exertion. So I'm worried. She's older. She's 65 and got dyspnea on exertion. Lower extremity edema is there. She's got a 20-pound weight loss in the last 3 months. She denies any chest pain, and her physical exam includes normal breath sounds, an early diastolic sound, followed by another diastolic murmur, best heard at the apex. So diastolic murmurs at the apex make you think mitral stenosis, right? But this is a weird one because it doesn't have an opening snap, and there's 2 of them. And then they've got lower leg edema, and the symptoms are worse when she bends over, better when she lays back. You see left atrial enlargement. What is the most likely diagnosis? So which of these is the most likely based on what we've just learned? Okay, so you put your answers in. Now, while you're doing that answer and you're thinking about this, think back to this, right? There's that pedunculated lesion. It leans forward. That's the most likely, right? So if you see that, why would you get left atrial enlargement? Look at that. So you got this big mass in there. It's going to make the atria get big in order to accommodate that. Makes sense, right? So you're physiologically thinking through that. Good. So most of you got that. Excellent. Right. Left atrial myxoma, most common benign tumor, and it's most likely associated with this patient. Perfect. Okay. This is just an explanation of this patient. One thing I want to mention to you about this particular patient, she has plectypnea, which is the medical term that she improves her breathing when she lays back. This is the only time it's ever used in that setting, and that's very few causes. So a patient that gets better with their dyspnea when they lay back, that's unusual. So you better start thinking myxoma. So keep that in mind. Plectypnea, that's where that's associated with. Okay. Surgical excision is the treatment for that. You just remove that tumor, that patient will gain weight, be good to go. Any questions on atrial myxoma? All right, good. All right, so now let's talk about the pathophysiology. Now, this is all set the same way when you're studying. We show arrows. We start from the worst and to go down the path. So you start with mitral stenosis, right? So what happens? So it's a filling problem. So you have a fixed cardiac output issue. It increases the left atrial pressure. What do you think happens when you do that? You get left atrial enlargement, right? So you would see things on the EKG like a large P wave, especially in V1. That would be suggested, like a biphasic P wave. Increased pulmonary venous and capillary pressures, backing up, right? The blood backing up into the lungs. Increased hydrostatic pressure leading to lung fluid and eventually CHF and dyspnea. What makes it worse? AFib, right? You can't overcome that stenotic lesion if the atria aren't contracting. That would be bad. And we know that you would be absent an A wave or an S4 if it was AFib. So that would make it highly suggestive that would make it worse. Tachycardia is going to make it worse. Heart rate's increased. Pregnancy is going to make it worse because you increase preload, which makes more work on the heart. And is this the only associated with left atrial myxoma platypnea? No, there's other causes, and we're going to go over them. That's just one, but it's pretty high on the differential. There's other things that can cause platypnea, but not many others. So we'll go over those later. All right, so keep that one in your differential. Start adding to your slide deck of learning. Okay, so now pathophysiology, mitral stenosis, stenotic lesion. What's happening is the left atria is getting big, so the pressure backs up, it goes into the lungs. Okay, that's what's happening. Not much is getting down in here for filling purposes, so it causes it to back up, and that's going to cause pulmonary pressures in your lungs to go up. So you would expect fluid in your lungs and elevated pulmonary pressures. Okay, so it occurs between S2 and S1. It's a diastolic murmur, right? Diastolic. So the key is it's during the filling cycle. Why? Well, when it backs up that fluid, you have two options that can occur. You can have passive pulmonary hypertension or reactive. Passive means the fluid's just backing up and the pressures are increasing. That's the most common. But then there's this reactive one, which is highly concerning because it causes permanent damage to the pulmonary artery and it gets hypertrophied. That's bad news. These patients don't do well and require more intensive care. So if there's pulmonary hypertrophy and it's reactive, that's terrible. On physical exam, what would suggest pulmonary hypertension? What might I hear with the P2? What would the P2 be that would give away pulmonary hypertension? Loud P2. Lots of things can do loud P2, and we'll talk about those, but pulmonary hypertension's in the top of the differential. Okay, pulmonary hypertension, it leads to what? So you've got the lungs are high pressure, so it causes the right ventricle to get large because it's got to overcome it. The right side of the heart then needs to get bigger to push blood through to the left side. So it enlarges, and you get some regurg, tricuspid regurg, because the pressure is pushing against that valve, which increases the right atrial pressure, and eventually you get right-sided heart failure. Okay, that's what pulmonary hypertension will do. And that's all associated with this mitral stenosis that's building up. Now, if it's chronically elevated, the left atrial pressure is chronically elevated, you get overload. And what happens, that's just the same thing like volume overload, is this pressure overload causes the left atrial enlargement. You disrupt the conduction, which leads to AFib, very common. Ding, 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 very common. Left atrial pressure overload is very commonly associated with AFib because the pressure pushes against the atria, stretches them. When the atria gets stretched, it triggers AFib, and that is not good. And you get decreased cardiac output, stagnation of blood flow. And what we really worry about is intra-arterial thrombosis and a stroke. Check on learning. Where does this thrombus most likely occur? Where is the thrombus coming from? Where are we? Left atrial appendage, right? Left atrial appendage. And we're very concerned about that. Now, this is an important one. The features of mitral stenosis, the top leading diagnosis that or sign that patient comes in, sign and symptom, is dyspnea on exertion. But occasionally, this is one of those murmurs that has hemoptysis, blood. This is an unusual one. Not many of them do this, and I'll explain in a minute why. but the left atria gets very big and compresses against the esophagus and the trachea and makes it bleed, and you get hemoptysis associated with it. AFib is very common, and all of the other symptoms that we just talked about. Dysphonia also occurs because of impingement on the laryngeal nerve, which is very common. You compress that nerve and it will cause dysphonia. Okay, so check on learning. Let's do a question. 42-year-old female with no significant past medical history presents to the emergency department with hemoptysis of acute onset. She has noted recent dyspnea on exertion, now to the point where she can only walk a half block before she has to rest. So that's dyspnea on exertion. She denies chest pain. Her temperature is 37 degrees. Blood pressure looks good. Respiratory rate looks good. Pulse ox looks fine. Physical exam, a irregular rhythm. What is that? What is that? That should make you think of what's going on. That's AFib, right? Early diastolic murmur, best heard at the apex. I like that one. Okay, early diastolic murmur. One pitting lower leg edema, and she has normal labs. EKG looks a little bit different other than some sinus tachycardia and left atrial enlargement. What's the most likely cause of the patient's symptoms? What's causing this? Okay, so put down your cause, jump in there and jump into it. Okay, jump into what you think it is. All right, so let's do your poll. All right, good to go. Everybody put your poll in quickly. Get it in. All right, so we're gonna, yeah, exactly. Mitral stenosis, very common, associated with hemoptysis. What's the most common cause of hemoptysis worldwide? What's the most common cause of hemoptysis worldwide? Tuberculosis. What's the most common cause of hemoptysis in the United States? Bronchitis. Bronchitis is the most common cause of hemoptysis. So hemoptysis and murmurs are rare, but when you see them together, you should be thinking mitral stenosis. Why would the lung sounds not have rowels or crackles from the backup? They could, but this patient just doesn't. Not, patients are patients, and varying degrees of stenosis, Amy, will present different findings. Not every patient that's in heart failure is going to have crackles. Not every patient that comes in with right-sided heart failure is not going, some of them do have crackles, even though it's right-sided heart failure. There's exceptions to patients. For the early diastolic murmur, does that indicate an S3, indicating volume overload? Make sure I'm not getting confused. So which earlier one, Mike, are you referring to? This patient we're talking about a diastolic murmur here at the apex. So that would not be associated with what we're referring to. This is a mitral stenosis. Okay. So just check on learning for this. Mitral valve stenosis, it's typically low-pitched diastolic, best heard at the apex, and it's going to have that opening valve. It can lead to congestive heart failure. That's why we're worried about it. And those are the solutions that you'll want to keep in mind. All right, so let's go into the physical exam a little deeper. So on mitral stenosis, it's low-pitched, rumbling, decrescendo diastolic murmur, okay? That's the key. All of these words are descriptive of that. That's what you want to write. And it has an opening snap, best heard after S2. And it's best heard at the apex in the left lateral to the decubitus position. And the duration of the murmur implies the severity. So the longer it lasts, the greater the severity, okay? Jerry said, isn't S3 also early diastolic at the apex? So what's the differentiator? Big difference. So S3s are going to be associated at the early diastolic. It's not going to be a grade 2. That's one thing that's going to change it. And it's, as you're driving your combination of this, it's more likely that this is associated with stenosis than an S3. I would not put it on an exam to have you differentiate them because it wouldn't make any difference, if that's what you're asking. All right. Okay, moving on to these next features. So always, and the other thing too, nothing, that's actually, Mike, I'm glad you brought this up. Let's go back to this question. Again, it's the whole totality of everything. You notice what you did, Mike. You narrowed in on one finding and said, let me think about an S3. Well, that's good, but your differential should include the whole enchilada. What's the patient history telling us? What's everything going on with this that's going to bring you down that decision making? Not a bad idea to think of an S3, especially with the 1+ pitting edema, but stenosis is more likely. Okay, good. All right, moving on to the next feature. So EKG diagnostic studies. Think about left atrial enlargement. P mitral. Where do we see it at? Look in V1. Biphasic P waves. This is the right atrium. This is the left. Notice how big it is. It's that big down. These are biphasic. That's the best place to look. You can also look in lead 2 and see right atrium over here, left over here. This little second hump is the big portion. You can have right ventricular hypertrophy and right axis deviation, which we've already reviewed, and then AFib, plus or minus. You can also see left atrial enlargement, very common on chest x-ray. You'll see prominent pulmonary arteries and curly V lines due to congestion. This is that V1 biphasic. Notice that the left portion down here is pretty big. So key V1 is where you see left atrial enlargement. You'll see that again. All right. This is gonna tell you that it's right axis. 1 is down. AVF is up. That suggests it. That gives it away. Okay. Look at this diagnostic test. Always remember your anatomy. Remember, the left atrium should be over here, but in this case, it's all the way over here. It's big, huge, and it's causing this massive change. Why? Because the heart's getting big and filling in. Okay. So barium swallow will allow you to see how big that left atrium is. So if you got somebody with hemoptysis and you're trying to figure out where the source is, you could do a barium swallow, especially if they had dysphonia and you're trying to figure out what's causing this obstruction. They'll do this barium swallow to see, well, the left atrium is sitting here and it's beating against the esophagus and in that tight space, and it's just pounding it over and over and over several times a minute, 100,000 times a day, and it beats it and it causes it to bleed. So you can actually cause erosion from that area, and it decreases it, causing hemoptysis. So your idea behind this of mitral stenosis is your first diagnostic test for all murmurs is to go ahead and do a transthoracic initial test, and then we'll go into more invasive based on what we find. So we'll always check, we try to get the diagnosis first, and we know the severity of the mitral stenosis is going to drive other things. If it's more severe, we'll see left atrial enlargement, might see pulmonary pressures going up. We might see concomitant other lesions that are associated with it. We might see tricuspid regurg, and we're going to determine whether the condition is suitable for a balloon. Can we go in and dilate it? Just like we do for artery, we can go into that and actually take that stenotic component and take a balloon, pop it in there, and dilate. That's called mitral balloon valvotomy. Now, look at the diagnostic studies. Look where this left atrium is. It should be over here, but it's this big because of the size. It's unbelievable. What test to confirm left atrial enlargement then is a transthoracic echo. Transthoracic echo. So barium swallow is done if you feel that the patient is having an obstruction in their esophagus. You would do a barium swallow. Symptoms would be suggesting that food's getting stuck. You saw how big that was. It's compressing against it. That patient's going to have difficulty swallowing. So you're going to see that as well. That's why the barium swallow was done. But you typically, if you're just looking for left atrial enlargement, yeah, you're going to go with an echo. And you can see these huge left atrium. Look how big this thing is. It's massive. And you can see why it's beating against that. And you can see where that left atrial appendage. Not dysphonia, dysphagia. So dysphonia would not necessarily make you think to go order a barium swallow, but dysphagia would. So, yeah. Okay. Transesophageal echo is in mitral stenosis, should be performed to assess that presence of that left atrial thrombus. We know that. And we certainly would do it before we would actually do a mitral balloon valvotomy. We would actually do it at the same time. You'd have to be sedated. We would do that tubing all at the same time. We'd put the camera below and then go in and do the procedure. So that's the idea behind that. Transthoracic echoes are not they're just not, they're not adequate if we need to, it's the best test is the transesophageal echo. All right, so now we get into the treatment. So mitral stenosis is that blocked valve, things are backing up. The pharmacological therapy on this is diuretics and salt restriction. So it assists in the symptoms to control vascular congestion. So we want to think, we're starting to think about heart failure, things that are going to assist to reduce the amount of fluid in the lungs. Salt and water, so they go hand in hand. Wherever salt goes, where water follows. So if you reduce salt, that'll decrease the amount of water that's in your lungs. Vice versa, same thing. Diuretics will remove the amount of fluids. So we'll get into Lasix and furosemide and talk a lot about that, both here and pharmacy. Beta blockers and non-DHPs, we're going to assist by decreasing the ventricular filling. We're going to increase the ventricular filling time. So what beta blockers do is they decrease the contractility of that ventricle, allowing more filling time. Same thing with calcium channel blockers. So you just get increased filling time. So it's a matter of increasing it. So it's all about those key components with this. Baxter said, so if somebody has mitral stenosis, if they have hemoptysis and dysphagia, we will go ahead and do a TEE rather than, no, I never said that, Baxter. So make sure that's a great question, but no, I didn't say that. If their initial diagnostic test is always the same. You're going to do a transthoracic echo to confirm what it is. And then if you're going to do treatment where you're going to dilate something, you'll do a transesophageal echo. But stepwise approach. Go slow, do something non-invasive before you do something invasive. Does that make sense, Baxter? So you want to make sure you do something non-invasive before you do something invasive. And then we're going to focus on digoxin as a choice for patients with AFib that can't do rate control. We're having difficulty with the atrial fibrillation with these patients. Digoxin's a good choice because it'll improve the contractility of this. Digoxin has a major side effect that you'll get yellow vision. You'll notice that you'll start getting a lot of arrhythmias. It can cause any arrhythmia. Third-degree heart block is very common with it, and it has a lot of toxicity. And there is a reversal agent that you're going to learn in pharmacology that we're going to talk about in heart failure coming up that we can reverse it. So we do use it. But it is a difficult drug to manage. And then anticoagulants, which you learned before, are very important for AFib or anybody with atrial thrombus prior to them. We want to prevent thromboembolic events. So all these patients are going to be put on warfarin. And if they've got severe mitral stenosis, it's going to be for life. So they're going to be on it a long time. Would we give beta blocker or calcium channel blocker? It depends. And so there's a lot of variables, and it's in heart failure that we'll talk about this. So right now, just know that you could do either. When we get into heart failure, we'll separate them out. Would we want to choose a beta blocker or would beta blocker? So when you deal with the beta blockers, you use the same concept that we did before. Under the age of 65, metoprolol and atenolol. Over the age of 65, carvedilol. It'll follow you well. Don't change what worked well. It'll always work. Jacob said, okay, we got those. Okay, good. So yeah, that's how you want to approach it. All right, just to check on learning, once again, all patients that have AFib and associated mitral stenosis, they're going to be on long-term warfarin for life. Just make sure you know that. Okay, that's going to be a key thing. Mitral treatment. So these patients tend to be sedentary because when they're active, they have symptoms. But we want them to exercise because if they don't exercise, they develop heart failure. We've got to get them exercising because you've got to get the fluid moving. Patients who have heart attacks and heart failure need to exercise. All those patients with heart attacks, heart failure need to exercise. There's only one class of patient we don't exercise, and that's the last stage of heart failure when you have symptoms so bad at rest you can't do anything. But other than that, everybody else needs to exercise. Okay, because it impacts their overall fitness. So sudden death is rare with mitral stenosis. That's why we don't really worry about it as much, and we can get them activated. This you don't really need to understand, but it's just telling you that, hey, they recommended based on all the data that yes, physical activity with mitral stenosis is important. Okay, very important. Mitral stenosis treatment continues. We could do a valvotomy or a valve replacement, and it depends on the severity. What you want to remember is that you're going to refer these to the cardiologist that will make this call. They will typically either do a balloon if the patient is referred for anything other than congenital, because this is the preferred test when we do valvotomy, is the preferred procedure unless it's congenital mitral stenosis. Why? Because valve replacement is invasive. So if we can get away with doing a valvotomy, it's great. There's two types of procedures. There's this open commissurotomy, which is open surgery where you're actually looking at the valves. It's more concerning, where a valvotomy is a balloon. And so that's nice. And then the valve replacement now can be done without open surgery, which is nice. You can actually feed it in through the artery up into the mitral valve and do this surgery remotely. It's pretty cool. And it can be done in 10 to 15 minutes. It's amazing. So you can really replace these quick. The long-term warfarin use is due to the long-term treatment of the valve. So it's because, the reason why is because the mitral valve leads to atrial thrombosis. And so you got to protect the stroke issues. That's why. Right, Ryan. So it's all of those issues that tie it together. Okay. Now, there's some evaluation as primary care that you're responsible for. You need to know when to do echoes. You got to do serial echoes in asymptomatic patients, okay? And there's a stage. So every 3 to 5 years if they're mild, every 1 to 2 years if it's moderate, and every year if it's severe. And yes, you're expected to know this. The sizes make a difference. If I were you, I would focus in on the severe one that you're going to do every year, because that's the most likely question that's going to come up. If it's less than a centimeter squared, you're going to do evaluation of it. Or if their symptoms change. So if I have mitral stenosis and I come in and I had my echo 3 weeks ago, okay, by PA Smith, and today though I'm having more symptoms, you get a new echo. Okay, it didn't mean that 3 weeks ago, who cares? You get a new one. So that's what this is saying. So if you get new symptoms, you get it right now, okay, to evaluate it, even if you had it 2 days ago, okay? So when you're talking about the mitral valve area, this is the mitral valve area, okay? And so that they're referring to the size. So it's usually done in centimeter squares, okay? So if you look at a valve, so centimeters, this is 1 centimeter, typically that's 2, and that kind of gives you an idea about the size of the valve and where it's at, okay? Now let's look at the progression. Most of these progress, if in the absence of stenotic valves, they do pretty well. Most patients do pretty well with these. So as long as you're exercising and you control the heart failure, they're going to be good to go. Now let's look at mitral regurg. Let's talk about that. So mitral regurg is the opposite of what we just referred to, right? We just went through this process. So we've kind of went down the pathway. Now we're talking about something that's regurgitant, which is holosystolic. So this is also more female than male. The posterior leaflet is most oftenly affected because of MIs, right? Because the right coronary artery supplies that, and we've talked about that. And it can be isolated condition or other congenital heart diseases that cause it. Okay. Now, the main thing that we worry about is that mitral regurg can also be related to mitral valve prolapse. So a lot of mitral valve prolapse leaks, and you get a regurgitant murmur with it. So they're common, very common and associated with it. Plus, infective endocarditis is very common with mitral regurg. Trauma can do it. Rheumatic heart disease, we know early on it does that. If the heart swells, it pulls the heart apart, making the valve bigger, and there's leaking. And so those are very common with congenital leaflets, and calcification can also be a cause of regurgitation. All right, so secondary causes, things that are not directly affecting the valve that could do it. Acute MIs, we know why, because it ruptures the papillary muscle, and that pulls that leaflet. Ischemic changes, okay, stunning of the heart, remember all that, stunning, hibernation, all of those things come into play, and it causes the ventricle to not work out well. Left ventricular systolic dysfunction, especially due to hypertension. HOCM can do it, and then rheumatic fever. These are all secondary causes that can cause mitral regurg. Now let's look at the valve. These put it in perspective of where the problem lies. So if it's with the annulus, it's going to be some type of calcification, can be due to atherosclerosis, aging, those things. The leaflets can be degenerative. They can be affected by rheumatic disease, endocarditis, or hypertrophic cardiomyopathy. You can see it with a chordae tendineae can be affected by rupture, by MIs, endocarditis due to infection, or the papillary muscles can rupture all to death due to death. And then the cavity dilation because of dilated cardiomyopathy, which we're going to cover in lecture 5. Dilated cardiomyopathy makes the heart big. Everything's dilated. We'll pull that valve apart. So there's 2 types of regurg. It's either acute or chronic. Acute is very dangerous, happens quickly. Patients typically have a rupture of their papillary muscles due to an MI, and they're not doing well. They're going to be hypotensive. They're going to be sick. Chordae tendineae rupture from endocarditis, also sick. Blunt trauma, crashing, airbags blowing into your chest, bad news. Degeneration of the tissues, that will lead to problems as well with mitral regurg. So which one is which? We're going to talk about acute versus chronic now. So chronic is that myxomatous degeneration of the valve. That's the more likely thing that's happened, calcification of that area. Rheumatic deformity of the valve, that's the swelling of the mitral disease due to the fact that the heart is getting myocarditis, so swelling is pulling that valve apart. And then you're going to see congenital valve defects that we're going to talk about that you can be born with. And then extensive calcification along that mitral annulus from a variety of reasons, atherosclerosis or just aging. So here's the pathophysiology. So the size of the mitral regurg is based on several things. The opening, right? How big is the valve? How big is the heart expanded? The heart, if it's bigger, it's going to pull the mitral valve apart, and more blood's going to flow through it. What's the pressures, right? What's the resistance on the way out? And what's the compliance of the left atrium? And what's the duration of the regurg? How long is it lasting? So that's what we're going to look at. So an elevation of left atrial volume and pressure is going to cause more fluid to go in, and then it's going to regurgitate more. So more in, it's like taking a cup. I take my Coke, fill it up, and I let it overflow. It's going to flow back, and it's going to regurgitate back, right? So the more volume. Reduction of forward output, right? That's going to be a problem, because if I can't get the blood flowing from the left atrium into the left ventricle, I can't get it out the aorta. So it's a stopgap problem. I can't get enough volume out. So cardiac output's decreased. And then the volume-related stress of that left ventricle and diastole is a real issue. That's a problem for us. So here's the acute phase. So you're coming along, everything's normal, right? Normal left atrial size and compliance, because it's in the acute phase. You didn't have regurg before. So today you're healthy. Tomorrow your papillary muscle dies. What happens? Immediately, boom, high pressure in that left atria. Then you get pulmonary pressure in your lungs, congestion, edema. And so what then happens is you get decreased cardiac output, changes in that wall that causes it to dilate, and you reduce the ejection volume. You just can't get it out. So in the chronic cases, though, the body deals with it differently. You've had it for a long time, so it's slow. The left atrium gets larger and increases its compliance, ability to overcome. The body adapts. It's more of a normal left atrial and pulmonary pressure in chronic condition. Forward output is decreased, but it's not as massive. We don't see the same symptoms as with acute. But as time goes on, it'll eventually get to a point where it will be a problem as it progresses. But this is a chronic issue. It happens over weeks to months to years, and this happens in days to hours. So acute mitral regurg, what we're really worried about, it's emergency, okay? It leads to this. It is a cardiac emergency. Well, how do we know it's there? Well, we know that the patient was normal yesterday, and today their reduced cardiac output, their left atrial pressure and volume is down, and we're running into pulmonary hypertension and pulmonary edema. We get decreased cardiac output, And what we see is the body's trying to deal with this pressure. So it tries to compensate, but it can't because the blood's backing up the pump. Should be going forward out the aorta. It's going back into your lungs. So all this is backing up, and the body has a heart failure, and it's typically on the right side. So all these fluids go backwards. Mitral regurg pushes everything backwards to the pump. So your problem winds up being failure of the right side of the heart because it just can't keep up with that volume in the acute phase. In the chronic phase, it's a lot slower process. You get more hypertrophy, changes of the heart on the left side, and it eventually gets to a point where it just can't keep up with it. So acutely, it's going to be more affecting the right side of the heart, chronically, the left. And that's really the key takeaway message between these pathophysiologies. Now, here's another way to look at it. Normal pressure, left atria, right, pushes blood out. In mitral regurg with pulmonary edema, what you see, okay, in the acute phase, so this ruptures, something happens, the blood volume goes both ways. It goes out the aorta and also back into the left atrium. Well, the left atrium doesn't know what to do. It can't dilate or hypertrophy, so it allows the fluid to go in the lungs, causing pulmonary edema. In chronic cases, the body slowly builds this, and it builds a defense. So the left atrium gets large. We see changes on EKG, big P waves. We see the biphasic P waves, very common with that, with left atrial enlargement, more suggestive of chronic condition, okay? And that helps you differentiate those. Now, the signs of mitral regurg, both acute and chronic, have very similar symptoms. Dyspnea, PND, orthopnea, palpitations can occur, peripheral edema, and arrhythmia. The palpitations are due to the stretch of the left atrium, which causes the same issues, AFib, and other things that we've saw with the stretch. Eventually, what we're worried about with the acute is flash pulmonary edema, massive fluid in the lungs, and heart failure. Typically, acute is right-sided heart failure. Chronic, we're more concerned about left-sided heart failure, more chronic issue. The differential diagnosis is clinical. Right, that's right. Yep, you separate them out clinically. Right. Now look at this. What is the most likely diagnosis here? Start your poll. Oops, I put the, it doesn't matter. You guys can just pick. I put A, B, C, D, and E, but you only have A, B, and C. If anybody picks E, we know you're not paying attention. Somebody will do it just out of pure merit. All right, most of you guys are tracking along pretty good with this. Yeah, so you're looking at this, it's irregular. You see the waves there, and you see it here. It's irregular, and there's no P waves. There's just no P waves. That's the key thing. When you look down the EKG, they're just gone. So when you look at that, absolutely, exactly right. The atrial fibrillation is most likely. Flutter is, one, it's very uncommon, one, okay? And two, it'll have very classic flutter waves. Okay, flutter is very uncommon. Okay, moving on to the next one. So on physical exam, you're going to get an apical thrill. So if you feel at the apex, there's all that fluid racing back from both sides, from the atria coming in, going out, right, going back into the left atrium, and also splashing from it's trying to fill that left ventricle. So it makes the apex move. So you feel a thrill. And when you move, it's doing this. It's moving around. But there's going to be a soft S1 and a wide split S2. You guys saw this on the previous exam. Wide split S2 occurs during inspiration. All right. So the pulmonic valve and the aortic valve are split widely. And it's going to be associated with a holosystolic murmur that's going to be heard at the apex with an apical thrill. And it's going to have a particularly loud P2 associated with it, especially if there's a pulmonary hypertension associated with it, okay? And that's going to cause the apex to displace to the left. So when you feel it where it normally is at, it's going to move. And it's going to be moving around because of that regurgitant murmur. Regurgitant murmurs make the heart bounce back and forth, so it'll move on you. And that gives you an idea. All right, so can acute mitral regurg be related to pericardium cardiomyopathy? Yes, it can, Jacob. And we're going to talk about that. And actually, that's one of the dilated cardiomyopathy things. The heart dilates from postpartum cardiomyopathy. It dilates it and it stretches that valve. So very common. I wanted to clarify that acute and chronic, right and left respectively. Yeah, so acute mitral regurg typically affects the right side of the heart. Chronic typically affects the left side. Okay, there's a mixture, but that's just kind of an idea of the thinking. Why would left atrial dilation show as left atrial hypertrophy on the EKG? So dilation and hypertrophy occur together. So the heart dilates and hypertrophies. They typically the process of the body is to make, they work dynamically. They're very common. One will be more dominating than the other, but they'll both work together. They're a little different. They're not distinctly different. You get dilation and hypertrophy that can occur in the same patient. Very happens most of the time. So dilation will be the predominant feature, or it'll be hypertrophy, one of the two. Yeah. And all right, so there we go. Yeah, they're not distinct. Good, Schmidt. I'm glad you brought that up. Wouldn't left atrial enlargement correlate with left ventricle hypertrophy? Now think about that. So the left ventricle the blood's going this way out, right? So if you're dealing with mitral regurg, the problem is from the atria. Atria need to pump the blood through. Left ventricle doesn't care. It's not going to get bigger because of the regurgitant issue. It's only going to get pressure from the left. It's coming from the left atria. So the left atria is going to be the predominant problem. Okay. Think of where the blood's coming from. Yeah. So Ryan said right-sided of the heart is mostly due to left-sided heart issues. That's true. So, but we're dealing with heart failure, Ryan. Stay with me. Stay with this right now, guys. Don't jump ahead. Stay with just learning mitral regurg, and then we'll get into heart failure. Don't try to put it together yet. Okay. All right. So think the chronic issues. So chronic, it's the same murmur. It's a loud, high-pitched, holosystolic murmur at the apex, right? With a loud S2, same thing we just heard. Why? Because it does the same things. Best heard at the left lower sternal border in that left lateral decubitus position. We know why, because it brings the heart closer to that location. And it should intensify with hand grip. Not always, but it makes sense, right? You squeeze your arm, that makes more blood regurgitate back up into the left atrium, and it can radiate to the back. So it's common in those issues. Now, on physical exam, the quality of the murmur is going to be important. So mitral regurg can be described as holosystolic, pansystolic, but during the acute phase, it has a little different nomenclature. During acute phase of mitral regurg, you hear an early mid-systolic murmur with decrescendo quality. What does that sound like to you? What have you heard that before? Where does this sound like in associate? Mitral valve prolapse. Exactly. So this is the association. Early mitral regurg in the acute phase is associated with mitral valve prolapse. And that's what this is, why that murmur sounds like that. You would not need to distinguish these two, okay, from each other, because mitral valve prolapse and regurg go hand in hand unless there is no holosystolic component to it. But during the acute phase, it's suggestive of it based on their acute symptoms. All right, EKG. Atrial fibrillation, we're going to see that. Left atrial enlargement, and you can get an associated left ventricular hypertrophy, LVH, if it's chronic, not in the acute phase. Acute phase, you're not going to see either one of those. You're not going to atrial enlargement or ventricular hypertrophy, right? That regurgitant murmur, but chronically, the fluid coming back and forth will do that, okay? So that part of it would be good. Would you say that part again on the left sternal border? Yeah, so where you hear the murmur at is best at the apex in the left lateral decubitus position. That's where you hear it the best. On chest x-ray, you see cardiomegaly. We saw that left atrial enlargement, and I'll show you LVH here in a minute, and possible annular calcification, okay? So let's look at this. So this is where the left atrial appendage is at. This is actually the left atrium. The whole thing is that big. It's unbelievable. It's huge. And then it backs up. So we shouldn't just associate mitral regurg or mitral stenosis with AFib, but rather than things that cause left atrial enlargement. Yes, good. OT Anders right. The differential's this big when you talk about that with AFib. Lots of things cause AFib. A lot of things are associated with it, and we're going to get into all those. All right, so the left atrial margin, this is, believe it or not, that's how big this is right now. The left atrium is that big. So that's, you can see the actual wall difference on that one side. So that's kind of interesting on the chest x-ray. All right, so we initially do a transthoracic echo on the chest, and we look for that left atrial enlargement, LVH, and for potential other problems, like what's maybe causing it. So we'll look and see what the baselines are, and then that'll help us quantify the severity of the regurgitant murmur, okay? So the echo, what does it help us really do? It gives us the idea of hemodynamics. That's what I'm really interested in. Wanting to know what their hemodynamic status is, I can see all of that. I can estimate their ejection fraction. I can see the flow. All of those things are happening with the echo, okay, what we've already learned. Shouldn't we just associate, okay, we already talked about that. All right, exercise Doppler echo. Okay, so this is an important one. If you want to see in patients that are asymptomatic whether their regurg is affecting their pulmonary arteries, you got to do it during exercise. And it also tells you the severity of the mitral regurg that could drive whether you're going to have surgery. So you can get them on a treadmill, they can be running, and then you do a Doppler, which is blood flow with the echo, and it will confirm whether or not that mitral regurg is severe enough to increase the pressures in the lungs. Other things we can think about. So now we got to talk about treatment. So there's a big difference between the acute treatment and the chronic treatment. So the main difference is that we're wanting to make sure that the blood gets out of the left ventricle and we prevent pulmonary congestion. That's what we're trying to do. So we have two options. In the acute setting, we can decrease preload, right? So if we decrease preload, that's going to help the whole entire system. So we can use diuretics and vasodilators, okay, to do that. And we'll talk about the diuretics, furosemide as one of our big ones. Bumetanide is another. You guys are learning that in pharmacology. And then vasodilators, there's many of them to include things such as ACE inhibitors. Nitroglycerin is an option. We can do it, and you can titrate it to do vasodilation. And surgical intervention as an option once the patient's stable. Chronic, there is no benefit from meds. They just need surgery. Chronic, there is no benefit of putting them on meds. This is not going to help them. They just need surgery. So you refer them for surgical intervention. Acutely, meds is what we do to try to drive stability. During the chronic phase, they just need surgery to replace that valve. Okay, so here's the way to put it in context. Mitral regurg that's acute is usually due to papillary muscle rupture from an MI, and they need a valve replacement. That's where you're going, but you can manage it initially with some meds. What meds? Well, we can use those vasodilators to decrease afterload like we talked about. We can kind of work through some of those. We can decrease some of those components, and we can decrease those elements. But long-term, you're both mitral chronic and acute both are going to need to go and for evaluation of whether that valve needs to be replaced. So one of the key things I try to get you to think about is in the acute phase, the medications that are going to really help the most with these vasodilators are going to be probably like things like nitroglycerin that are going to drive this. And we'll talk about this a lot in heart failure, okay? But right now, I just want you to focus in on that there's two different treatment plans for both acute and chronic, all right? So don't get too spun up in this because you're not going to be managing the details of these two elements. You just need to be familiar with them. All right. The bottom line, what you are responsible for is this. These patients need to be referred for possible mitral valve repair or replacement, and you refer them to a specialized center. When you find these patients, they need an evaluation of that to be looked at surgically. Okay, those are key components that we've got to do. All right, so we're finishing up this, and then we'll take a break, and then we'll go into the next discussion. Last thing here is this mitral regurg. Can be very stable for years if it's mild. Moderate, we need to be referring moderate to severe, you're thinking surgery, because they can die if you don't do anything about it. So we want to do those components. All right. Check on this one before we take the break. Which of the following is a functional cause of mitral regurg? Which of the following is a functional cause? So O.C. Harris said, going back to the last slide, the goal for acute management is the treatment of the aortic balloon pump or vasodilators until surgery. Yep, you're correct, O.C. Harris. You're on it. Exactly right. Good job. Okay. All right. Most of gave you enough time on this one as you're thinking about it. All right. Let's post your responses. What you wanted to think about, the etiologies of mitral regurg are complex, right? So here's where we're wanting you to think about. What are the problems with it? Mitral regurg can happen due to a lot of things. It can be organic or functional. So if it's organic, it's due to all the causes that are inside that valve. Or if it's functional, it's something around it. That's how you separate them out. So most of the cases, when you think about this, are going to be listed in the category where you're going to see that the majority of these patients are going to typically have a functional component that's going to drive that component. Can be organic, but the functional is likely to be a problem. So as you guys are looking down this process and you're trying to figure out what's the functional cause of mitral regurg that's going to be associated with this, most likely going to be due to dilated cardiomyopathy. Dilating the heart, making the leakage go through that, that is going to cause mitral regurg. So that's the functional cause. You can have organic or functional, dilated cardiomyopathy being the most common. All right, good. Checked on that. You guys are all over that, ready to go, and it'd be good. It's Baxter said, it seems the two slides contradict each other on chronic mitral regurg. No, they don't. They're talking about during the management of chronic patients. Chronic patients can have an acute phase. So when they come in, when you're talking about this, when you're looking at these two slides, this is talking about treatment in context of what you can do initially before you can go to surgery. What we want you to remember is that meds aren't the priority for this patient. You're not going to manage this outpatient. In the acute phase of this, which it can have an acute phase, you'll use these meds until you get them referred for surgery. That's what it's telling you. Mitral regurg, same idea. Acutely, you can manage with meds until you get them stable and then move them to surgery. Both go to surgery for evaluation. One of them, though, the chronic mitral regurg, we don't want you to think, oh, I can just put them on ACE inhibitors and they're good to go. That's not the answer. You might manage it acutely, so they don't contradict each other. They just give clarity to the fact that when you read Lilly, it tells you that you can't set on these patients as a primary care. You've got to refer them for surgery. That's what it's telling you. Okay, good. Yeah. All right. Take a break, and we'll be back in 10. Oops. Back on recording and jump into mitral valve prolapse. So it's an abnormal displacement or one or both of the leaflets into that left atrium. So you get what they call a systolic billowing, and it's not regurgitation, it's a prolapse. So it's kind of weird. Can you get, people ask this question, is mitral valve prolapse always associated with regurgitation? And it is about 80% of the time, but in some cases, you'll only get billowing of it. And so it looks like when you look on echo, you don't see the fluid going back into the left atrium that you would see with mitral regurg. But this billowing occurs with 2 millimeters above the annual plane. That's how you would diagnose it. Not critical to know that, but that's the key. It's the billowing discussion that helps you know that on echo. All right. There are some causes, though, of mitral valve prolapse that you need to be very aware of. It can be due to these really severe causes of mitral regurg that we talked about, the organic causes that we know that are there. And they can be familial or they can be associated with things. Marfan's being one of them. So ectopia lentis is implied that the lens in your eye lens is actually slipped down due to being stretchy. And pectus excavatum is very common in these patients with pes planus, flat feet. They have a positive wrist and thumb sign, meaning they can actually pull their wrist and thumb backwards. So it lets you know that they're real stretchy. That kind of gives it away. Okay. And then Ehlers-Danlos syndrome is also stretchy. It's the same idea that you've already seen in pathology. So Ehlers-Danlos, with a history of that, should make you think some type of mitral valve prolapse. And then osteogenesis imperfecta, typically in newborns. And what color is their eye? What's the main thing that we think about for osteogenesis imperfecta? Yeah, it's blue sclera. Right. So that helps you pull it out. And then there's lots of sequela from cardiomyopathy and MIs that we've already kind of been hitting on. So most of these are asymptomatic. That's the key with this. And it's tied in. For whatever reason, it's not letting me start the camera. So I apologize to you guys, but it's the best I can do. It's kicking it off. It's saying there's not enough bandwidth. So no camera right now. Key clinical manifestations are going to be found on oscillatory findings. That's how we diagnose it. And we're going to get an echo if we are concerned about this particular diagnosis. So there's a mitral valve prolapse syndrome that we want to be worried about. So it's typically associated with mild to sometimes stabbing chest pain. Dyspnea can be there, palpitations, fatigue, dizziness, exercise intolerance. It's similar to what you saw with mitral regurg, but there's something that's also associated with it that's an embolic phenomenon. If you have an ASD, okay, a hole in the right side of the heart, okay, this is ASD. Let's say you do, okay, and you have this mitral valve that's billowing up, you can get a embolus that comes up and goes out and can cause strokes. It can also go through this hole and go into the lungs and cause pulmonary embolisms. So it's kind of a rare time when the arterial side can cross over due to this pressure of this billowing valve. So that's what this is talking about with this embolic phenomena that can occur with a hole in the heart. Now, one of the key things that you hear on exam is a mid-systolic click with a late systolic murmur. We've been over this several times. That's one of the key features. And you notice that that's one of the key descriptions for acute mitral regurg as you hear this mitral valve prolapse. The click is thought to be caused by the snapping of the chordae tendineae, but we're not exactly sure. There's some discussion about it. And when thought means we don't really know. But the valve bows into the atrium. That's one of the key things it does. So the bowing is one of the key things. And it's accentuated or altered by certain things. And we know that mitral valve increases with standing, and it also increases with Valsalva, and it decreases with squatting or lifting the legs, things of that nature. EKG on these patients is typically normal. Chest x-ray doesn't really show much because unless it's really got severe mitral regurg, it's not really that big deal. Echo is going to show the billowing of those mitral valve leaflets into the left atria, and it'll help you, diagnose mitral valve prolapse pretty easily. Most of these patients are going to be asymptomatic. We don't really need to do much with them, but we're going to confirm it with the echo. Now, I'm sorry, that was talking about the EKG portion. I apologize on this. So when you talk about in context of the echo and the EKG is not, you're going to get one on all those patients, but echocardiogram is going to really confirm the diagnosis of these patients when you're dealing with these. Transthoracic echo would be first, always first, Baxter. Always go with that first, and then you only want to get the transesophageal echo because it's invasive if you need to for other reasons. But just to confirm the diagnosis, you want to do a transthoracic echo. Good. All right. So then as you move on, the other thing is that most of the time they've described that it's not necessarily indicated in asymptomatic patients, only symptomatic. That's the ones you have to get a echo on. But a lot of people still do it. They still get confirmation. I'm not going to test you on that because that's a art of medicine, not an exact science. All right. So the treatment for mitral valve prolapse, you want to use aspirin, antiplatelet, anticoagulation if there's AFib or systemic embolism, you might want to consider these patients. If the AFib, you're going to treat it, put these patients on long-term warfarin if need be, if you can't fix the AFib. We'll talk about how to treat the AFib in a minute. Now, one thing they did is they took out in 2007, there's no longer prophylaxis. So if you go in for a dental procedure, for example, and get your teeth cleaned, you get bacteria in your blood. It can go to the mitral valve and create a nidus for infection. So they no longer require you to do that with patients with mitral valve prolapse, even with regurgitation. So now the mitral valve prolapse syndrome that patients can get, you just typically reassure them because they get palpitations with it. It's all TLC and avoiding caffeine, alcohol, and reducing stress and fatigue. So it's pretty, those who do have it, it's more common in women. They'll have these palpitations with the mitral valve, and the cure to it is, of course, decrease these components. All right, so prognosis of mitral valve prolapse is good. There's cardiac survival is long-term. It's not a big issue. All right, so check on learning. You have a 75-year-old, otherwise healthy woman states that she has passed out 3 times in the last month during her daily brisk walk. Which of the following is the most likely cause of her syncope? Most likely cause. Is it aortic stenosis, atrial myxoma, orthostatic hypotension, or vasovagal syncope? Okay, most of you have got your answer in. All right, so most of you picked aortic stenosis, correct. Atrial myxoma is going to be associated with weight loss. It's going to be associated with a diastolic murmur that moves. It's better when you lean forward. Orthostatic hypotension is going to be associated with blood pressures that change when you measure them when they're laying down and they stand up. And then vasovagal syncope is really usually a younger person's disease, not considered typically in older people. If this was a 25-year-old woman, you might consider this. Okay, but aortic stenosis in the old patients where you need to be thinking along that lines. Good. All right, moving on to the next portion here. So Jerry, it is in the right patient population. So there's a lot of causes of syncope. It's the one that you need to be thinking about for valve disease. So syncope with exercise, it's usually a sign that the heart's not getting enough output. And it's commonly occurred 42% of these patients with severe aortic stenosis. So it's not the most common, right? But it is up there. It's high. There's many other causes of syncope, like MIs, congestive heart failure, other things that we have to worry about, but this is one of them. And the pathology of aortic stenosis is similar to atherosclerosis. It leads to lipid accumulation, inflammation, and calcification. And that's what we're going to look at right next. So, yeah, it's kind of tying into the overarching thing of what causes aortic stenosis. All right, so it is the most common cardiac valve lesion in the United States. It's approximately, we see it about in 1% of the population are born with a thing called a bicuspid aortic valve. And these are problematic. If you're born with this, you have a chance to develop aortic stenosis at a younger age. So bicuspid aortic valve makes you at risk for early aortic stenosis. So if you had a 55-year-old woman develop aortic stenosis, is that usually due to atherosclerosis or is that usually due to bicuspid aortic valve? And the answer is it's due to bicuspid aortic valve. Yeah, so atherosclerosis is common in women over the age of 65, men too, men over 65, so older. So bicuspid valves are going to be younger people. How often are they unicusp? It's pretty rare. Unicusp, you don't usually live. Need to be surgery on those. Brad. So North American and European aortic valve disease is due to the following. So we think about these. So congenital bicuspid valve or unicusp, which these are rare. These are the most common congenital heart disease that we see across the board in adults. There's some other common components with these that we're going to talk about, but this is the most common with the aortic valve, okay? And congenital bicuspid valves are there. So when you talk about for the aortic, congenital is a very common cause. So 2 or 3 of the cusp fuse. It's most commonly seen in patients less than 70. So the example I gave you earlier with a 55-year-old gives you a pretty good indicator that that's where it's at. So when you're looking at these patients, young patients like a 40-year-old patient coming in, you should consider bicuspid valve as their problem. Older patients, on the other hand, are due to wear and tear, and it's the same issue, atherosclerosis and coronary artery disease, and they're usually seen in patients greater than 65. For exam purposes, greater than 65, you don't have to worry about bicuspid valve, that if I'm going to tell you whether they have it or not. But less than 65, I would expect you to pick out that the most common reason for early aortic stenosis is due to bicuspid valves. And that's important to know. Worldwide, rheumatic valve disease is very common. We know that. Now we know the mitral valve is the most common valve in the United States that's involved with rheumatic heart disease. Okay, so aortic stenosis has the following pathway. There's an outflow obstruction because it's stenotic, decreased end diastolic pressure, and you get concentric LVH. You also notice left ventricular failure, and then it'll go to CHF. Very common for these patients to get subendocardial ischemia. What is this equivalent to? What is subendocardial ischemia equivalent to? A non-STEMI, right? Exactly. That's what it is. It's a non-STEMI. So these are very common. So now you're seeing it all together. MI can be the very end product. So they get CHF and then they developed subendocardial ischemia because the subendocardium can't get blood supply because of the pressure of the volume overload. Because this stenotic lesions right here, it's forcing all this pressure that's building up in the left ventricle. That pressure keeps building up, and eventually it causes necrosis, and you get death. And that's the key thing. So these pressures are very high, right? In order to get the pressure out, the afterload in the aorta, I have to overcome that. So the pressure is high, high, high. So it comes out and it pushes this way. And when it does, it shoots out blood very fast, and you feel the pulse in your neck and the carotid. It's very intense. Okay, remember that this is a systolic murmur that's occurring between S1 and S2. The signs and symptoms, these patients are going to have, they can go long periods of asymptomatic symptoms, but the most common presenting symptoms are the following: dyspnea on exertion or decreased exercise tolerance. Very important. Exertional dizziness. Dizzy patients do not get discharged. Dizzy, if you don't know what's causing their dizziness, you keep them in the hospital until you find out. This is problematic, and it's usually, especially if it's exertional. And then exertional angina is always a problem too. You got to worry about that. So what causes angina? It's that imbalance. We just talked about it. The subendocardium, right? It's all these features, right? We just hit it. These are the pressure is so much in that left ventricle, it's causing a subendocardial ischemia. So when you think about that, that's why there's an imbalance in the oxygen demand. So why syncope? Well, the left ventricle can't get enough cardiac output, right? It's stenotic. And so the orifice, even with the vasodilation that we get, you can't get enough blood to your brain. So your brain doesn't get enough blood, and boom, you get syncope. So you decrease your oxygen to your brain no matter what the cause is, you're going to get syncope. And why CHF? Well, the left ventricle, that contractile dysfunction is due to that increased afterload, right? So the afterload causes left ventricular hypertrophy, which then leads to more pressure, and it backs up into the left atrium, into the pulmonary vasculature, because it backs up the back in the opposite direction, right? So if the left ventricle gets so much pressure, it's eventually going to get into the left atrium and then into the lungs. That's going to be the pathway that it goes. It's going to back up. Always consider what's on the back end of the pump. Yeah, pulmonary edema, exactly. That's what causes the CHF, is the fluid in the lungs. Right, exactly. Good job, O.C. Martinez. So your physical exam, you're going to have a crescendo, decrescendo, diamond-shaped murmur. It's systolic, okay? It's usually an ejection click, best heard at the right upper sternal border. You can hear it either with the bell or the diaphragm. We know you're going to hear it best with the diaphragm. It radiates to the carotids, okay? Very important. Pulsus parvis tardis, weak and late, rises slowly. That's what pulsus parvis tardis is. And this represents severe aortic stenosis. It's best appreciated in the carotid artery. We feel it when you get there. It's that weak and late and slow the rise. And you can actually palpate the PMI and the carotid at the same time, and you'll feel it. The PMI will be displaced due to left ventricular hypertrophy. And yeah, so left ventricular hypertrophy causes the heart to be displaced. So anytime the ventricle's big, where is it at? The PMI shifts. So the PMI is over here. Instead of, if it's normal, it'd be over here where it normally is. It shifts to the left because of getting big. And that's what displaces it. Narrow pulse pressure is very common with aortic stenosis. So keep that in mind. Very important to know that it's narrow. Why? Because it's just like hypovolemia. You can't get blood out. You're not going to have a real high systolic and diastolic pressure. They're going to be narrowed. Okay. Is aortic stenosis the only valvular disease that causes narrow pulse pressure? Nope, unfortunately not, but it's one of the most common ones. We'll get into them all. The other ones can do it too, but aortic stenosis should come to your mind for narrowed. It's certainly the one that you should be like, boom, yeah, I'm worried about it. Tamponade can also do that as well. Yep. EKG findings are related to that left ventricular hypertrophy. You're going to see left atrial enlargement. The patient may or may not have AFib, but if they do, it can be very severe, especially in the context with patients with severe aortic stenosis. Most of those patients are going to have some form of in and out of AFib, and it will definitely increase the risk of heart failure and stroke if they have it. So treating AFib is critical in severe aortic stenosis. All right, let me check on learning here. You're seeing a patient that has severe aortic stenosis and is having dyspnea on exertion. Is there any chance that you would ever order a stress test for this patient? Would you ever put the patient on a stress test, cardiac stress test? No, because you know it's severe. So don't do that on the exam, okay? So please don't do that. All right, so chest x-rays are key for helping us identify just the basic structures. We can see LVH, calcified leaflets, and we might suggest CHF. But the echo, transthoracic echo, is going to be king, and it's going to show, we're going to see it with the Doppler. That's going to be the best thing. And we're going to see a reduced valve area with these patients. So the aortic valve is going to be decreased. It's normally very large, can be up to 4 to 6 centimeters squared, and this is going to be much, much reduced. And so CT or MRI of the aorta could be needed, especially if you think bicuspid aortic valve. So if I have a 40-year-old male that has severe aortic stenosis that I confirm on echo, then I would want to order a CT or MRI to confirm a bicuspid aortic valve. Now, why do I care about this? Well, if you've had this for a long time in your life, you can have an increased risk of aneurysm in your brain and dissection in your aorta. Why? Think about this. You can get a baryaneurysm in your brain. All that pressure is backing up, and it's pushing all that pressure, and it's causing all those elements that are creating so much pressure to get the blood out that it's pushing too much pressure to the brain. And that can cause an aneurysm or dissection. Very common, actually. So I have to worry about those patients. And you got to look at the entire aorta with the CT or MRI, because you can't see it solely with the echo, right? So we want to look and see if they're candidates for valve replacement. This is kind of cool. You can actually take and replace the entire aortic valve now in 10 minutes without open heart surgery. They feed the valve in through the aorta, and it goes right in and places it. boom, they place it, pops off the band, and boom, you're done. And these TAVRs are awesome. So Donald said, is a CT or echo the confirmatory test for bicuspid aortic stenosis? Yes, it is. It is the confirmatory test. Initial test is transthoracic echo. Confirmation is CT or MRI. Yeah, exactly. Yeah, it's pretty cool. Plug and play those valves. It's awesome. That's one of the things I love doing out there. When we were out at the Mayo Clinic is awesome. Seeing those things are done. All right, exercise testing. Asymptomatic severe aortic stenosis. We want to confirm the absence of symptoms, right? So in the cases, if they're symptomatic, we cannot, under any circumstances, do a treadmill test. And so when we get that in place, now if they're asymptomatic, we might put them in under cardiology supervision. They might do a stress test with them. But for symptomatic aortic stenosis and from primary care perspective, we do not do this. So you'll refer them, let somebody else manage this. From our perspective as PAs, if there's severe aortic stenosis, we just don't do a treadmill test. They can do them, as you'll find out in Lilly, but it is very controlled situation. How do we know they have severe aortic stenosis? Okay, good. What on physical exam would suggest a severe aortic stenosis? You already know the answer to this, Harris. What on physical exam would suggest severe aortic stenosis? Would the A2 be loud or quiet? What happens to the A2 for severe aortic stenosis? It's quiet, exactly. The sound of severe aortic stenosis, the aortic valve gets quieter. The ejection click doesn't change because it gets quieter. It gets less and less as it gets more severe. So that's a shocker, right? So the physical exam, instead of it getting louder that you would think, it actually gets quieter. Okay. So treatment, medical therapy. What can we do? Activity limitation based on the intensity and the type of exercise that they need to do. Really, there's no real good medical management for these patients. They need a valve replacement. We want to use extreme caution in antihypertensive medications. We want to be very low dose and titrate with close monitoring. Makes sense, right? You're decreasing preload. That could cause them to have syncope. Diuretics must be avoided. Why? Because that's going to decrease cardiac output. If you've got something that's already stenotic, here's my left ventricle, right? This is stenotic. And then I decrease the volume coming into the left ventricle. Now you're going to decrease the cardiac output and lead to syncope. So diuretics need to be avoided in these patients. Okay. So no diuretics in severe aortic stenosis. All right. So what imaging are you required to do? At diagnosis, you need a transthoracic echo. The severity of this, we want to look, if it's mild severity, you'd get an imaging every 3 to 5 years. If it's moderate, 1 to 2 years, and every 6 to 12 months in stage C. We're going to learn about these stages, but A, B, C for heart failure, you're going to figure out in heart failure what those stages are, which will make sense. They're based on whether you have symptoms or not and whether there's organic structure. We'll focus on that in heart failure, but these are the associations that you'll come back and put these together with, okay? And then anybody changing symptoms. So let me check on learning. Whether you have mitral stenosis or aortic stenosis, let's say I had an echo 3 days ago and I was fine, okay? Now today I show up in your clinic and I've got dyspnea that's different from my baseline. Do another echo right now. Good. Yes, you don't go to these protocols and say, oh, well, we'll do it in 6 to 12 months. That would get you have to call the fours if you do that. All right. So the bottom line is these patients need an aortic valve. Okay, that's what they need. And TAVRs are the very common ones that everybody's doing nowadays. They're awesome. Okay, and then we got to decide whether or not the patient's going to get a mechanical or a bioprosthetic. Even though you don't decide as a PA what they get, the boards want you to know the difference. Mechanical valves are typically given to patients that are going to live longer than 10 years. So if your prognosis of your health status, let's say you're 25, you're going to get a mechanical valve. because you don't need it replaced. Bioprosthetic valves are the opposite. Because they're bioprosthetic, they need to be replaced every 10 years. So they put it in patients who typically are expected to not live more than 10 years because they only want you to have one surgery. So the advantages of bioprosthetic is that you don't need warfarin. It doesn't require anticoagulation. Mechanical, it does. But luckily we have new anticoagulants, the new DOACs for anticoagulants. So the new drugs of choice can be Eliquis. There's a lot of factor 10A inhibitors. There's tons of them. We're going to go over a bunch of them in the atrial fibrillation lecture, and you're going to learn them in pharmacology. Bottom line on it is mechanical, young people, and they're going to be on prophylaxis for a long period of time. Bioprosthetic, old people at the end of their stage of life. And bioprosthetic, you don't need prophylactic against a thrombus concern. So you're not going to need to put them on warfarin or one of the new DOACs. Mechanical, you are. Okay. So it's always a risky procedure to do aortic valve replacements. And if it's open, it's really serious. So that means you're opening the chest. So that's the last resort. You want to do a TAVR if you can. And then, as we mentioned, balloon aortic valvuloplasty, we can do that in congenital causes of aortic stenosis. You basically go in there and dilate it, and that can be done in young adults. Very rare that that's done unless an emergency need in an adult. Okay. All right. So the prognosis of these is pretty good until you get symptoms. You have to know this chart. Know it cold. Angina with aortic stenosis, typically the patient's going to live less than 5 years. If they have syncope, less than 3 years. Dyspnea, less than 2 years. Dyspnea is a problem. If you have dyspnea and aortic stenosis, not doing well. Okay. So remember, asymptomatic patients may not recognize their symptoms because I'm just getting older. I'm short of breath. I'm fat and old. Well, maybe not. So we are required to know that the patient may not tell us everything we need to know to get to dyspnea. You have to prove that. Okay. So the cardinal symptoms are these advanced end-stage diseases. We always know that angina, they're going to live about 5 years. Exertional syncope, 3 years. CHF, 2 years. This is a typical timeline. You can't it's not mandatory, but you can do things to treat these, right? So like angina, what could I do to decrease the risk of angina? What drug might I give that would decrease angina risk? Beta blockers, right? How about exertional syncope? What might I do to change that? What might I do to change exertional syncope? How about surgery, right? Replace the valve. CHF, prevent it. Put them on diuretics to decrease it. And we'll talk about those. And then AFib can precipitate heart failure and increase mortality. So this is important. AFib, it's the most common arrhythmia. You got to know everything about AFib. Level 3 for block 2. Going to ask you a ton of questions about AFib. How to treat it, everything you can learn about it, you want to learn. Okay. Prognosis of aortic stenosis depends on the severity. If they have angina, syncope, or heart failure, we know that's a problem, right? It gets worse. Or if they have dyspnea, that's an issue. Aortic insufficiency, this is the easier one of the ones to think about. It's this regurgitant blood going out the aorta, and then it comes back into the left ventricle, okay? And there's two causes. There's acute aortic insufficiency and chronic. They're both the same. The terms are exactly the same. Whether you're saying aortic regurg or aortic insufficiency, they're the same thing. Chronic is the most common etiology in developed countries, and it's most commonly due to bicuspid valves. Why? Because the valve is allowing leakage. And then dilation of the aortic root. I want you to think about things that we've talked about today that could cause a dilated aortic root. What could cause somebody to have an ectopic lentis, tall, pectus excavatum, and pes planus? Marfan's, right. You could also get it with syphilis. That's another cause. Yeah, Adam's right. Syphilis can cause a dilation of the aortic root. And we can also see this happen with rheumatic heart disease. Okay. It's a medical emergency in acute stages. If it's acute, it's a medical emergency. We've got a problem because these patients will die. It's most commonly due to endocarditis in the acute phase. Endocarditis is, if it's involving aortic insufficiency, it's the most common valve affected. Okay. Aortic dissection, it's most commonly in the acute phase when this occurs. And traumatic rupture of those valve leaflets can occur. What can we do? We can actually create it when we were trying to dilate the congenital cause of aortic stenosis. We blow up the balloon too big, and it kills the patient, and then you need to call the fours. That's not good, right? So the aortic balloon over dilates it. Or I put a TAVR in and it fails. That would be a problem, right? So if you replace the aortic stenosis with a TAVR, well, now you've got the valve is displaced. That's an issue. Okay, so those are causes that you can think of. The pathophysiology of this makes a lot of sense. You get volume overload due to the aortic regurg. So the left ventricle dilates, right? And it tries to hypertrophy to overcome it, and it increases systolic volume. You get a high systolic blood pressure and a low diastolic blood pressure. So you get a wide pulse pressure with aortic insufficiency or aortic regurg. It's the most common separation, and it's usually very wide. And then increased wall tension, leading to pressure overload, which is an S4. And this is why I gave you guys credit on the test on last week. One of you pointed out that pressure overload is associated with that same pathophysiology. So there you go. That's the benefit of reading ahead. Good job on that. Left ventricular hypertrophy, okay, is the end product. So we typically see aortic regurg associated with rapid decompensation. These patients don't do well. And what we can do is insert a aortic balloon pump in their heart and pump for them temporarily. Remember acutely how we talked about that? That can be the case. Oops, I don't know why I did that, sorry. And then chronically, these patients just get the chronic symptoms. They lead to CHF, and it's more likely due to the same pathophysiology, but a widened pulse pressure is the hallmark that you see on these chronic things. And that's really what's cool about this, is that those two diseases, you can manage them by replacing the valve, and acutely you can put the balloon in there and just pump for the heart and get until you can do something stabilizing. So think about acutely what's happening. So the pressure in the left ventricle has to get so high to get the blood out that it comes shooting back down against this ventricle. And when it does, it shoots so hard against this that it displaces the heart, and it causes blood to regurgitate everywhere. It just all over the place. It's just massive pressure with aortic insufficiency, but it comes back very, very fast, and it affects filling. So you get this wide pulse pressure. Same thing with chronic issues. The heart dilates and hypertrophies to try to overcome this pressure, but the blood comes back in, and that's what it does. It's so interesting. Now, remember that aortic insufficiency occurs during diastole, right? It's a diastolic murmur. That's the key. So the pathophysiology, same thing we just went through. It starts with aortic regurg, and it leads you with heart failure and all the things in between. So all of these can occur, and we know that once you start getting dyspnea, it's a bad day, just like you saw with aortic stenosis. So the signs of these are the key. Acute pulmonary edema. What is that? Short of breath and congestion. Chronically, what do? You get prolonged asymptomatic periods followed by periods where you get bounding pulses, water hammer pulses. A lot of patients will describe, I can't sleep at night. My pulse is bounding so much that they can't sleep. They can hear it. Water hammer pulse. They'll have congestion. They won't be able to lay back because of the heart failure. They'll have angina, and they'll be uncomfortable because of these forceful heartbeats. Okay, very important. Yeah, Corrigan's, it's coming up next. So this is where it's at. So the Corrigan's pulse is the water hammer. that you just asked about. D. Musset sign is the head bobbing. Quincke's pulse, which can occur in the nail bed or also on the lip. Trabé's sign is you're listening over the femoral artery, and it sounds like somebody is shooting a pistol. It does sound like that. It's pretty weird. You're listening and you're like, oh my gosh, what's going on? Listen over the femoral artery, and it sounds like somebody just fired a gun. It's pretty loud. And Durazé's sign is where you hear a murmur that's to and fro femoral murmur. What that means is that you're hearing it back and forth. It's coming. You're like, what's going on here? The murmur is moving back and forth. And that just because of that regurgitant flow makes sense. So the murmur is high pitched, it's blowing, and it's associated with, we typically see it in that Erb's point. Remember how I mentioned that the Erb's point is that cross pattern? Here's Erb's, and it's in that third to fourth intercostal space. Well, everything aortic comes this way, pulmonic this way. You get the crossing of the blood. So it's the systole that you're hearing. The systolic blood pressure is Trabé's sign, right? So the key is it's accentuated. All murmurs are accentuated when you lean forward and during exhaling, though, for aortic regurg. Why? Because it's left-sided. Notice that. It's a left-sided murmur. Exhalation is going to accentuate the murmur. So that's going to do it. So femoral has all cool murmurs. Yeah, exactly. The femoral portion does have all the cool murmurs. That's true. It does. All right, so physical exam. Valvular etiology. It's best heard in the third to fourth intercostal space. It can be heard in other locations, okay? You can hear it in the second intercostal space as a blowing murmur, but it's best heard here in Erb's point. If it's an aortic root etiology, it's best heard at the right sternal border and the apex. So if I've got somebody with Marfan syndrome, where do you think they're going to be best heard? Right here. It's going to be best heard at the right sternal border and the apex. Why? Because of the root dilation that's associated with it. It gives you a key thinking of what that might be. All right, so Austin Flint murmurs, we've been over this. You understand that it's a rumbling diastolic sound that's attributed to a normal diastolic blood flow from the left atrium hitting the anterior leaflet of the mitral valve. So it's aortic insufficiency and a physiological closure of the mitral valve. That's what you're hearing. And so people describe it as a diastolic rumbling, low-pitched, and then aortic insufficiency combo. So you get the combo murmur, and you saw that before. All right, EKG, you can see all the things that on the left side that you would typically see. Everything's going to be dilated and big, strain patterns, left bundle branch blocks are common. Why? Because it's affecting the conduction system in that area, and atrial fibrillation is very common. You're going to probably see pulmonary edema, especially if it's in the acute phase, and vascular congestion. And then in the chronic phase, you're going to see cardiomegaly with the ascending aorta dilated, especially in Marfan syndrome. Okay, this is what it looks like. Look how big the heart is with the congestion in the fields. Okay, very common, very common. Echo confirms it. Okay, we know that. We are going to get that key component, and we can look at it. If we're concerned about the aorta itself, we need to do a transesophageal, but we can do a transthoracic initial look just to take a peek at it. But if I want to confirm it, I've got to do a transesophageal echo, okay? I can also do a radionuclide angiogram or MRI as initial or serial assessment of left ventricular volume if I want to see that aortic regurg and see what percentage is there. And you can do what they call as an aortic root angiography for measuring hemodynamic measurements. So I can really see what that wide pulse pressure is doing. And then cardiac caths are another way to measure this if the patient is decompensating. And we've learned that with the Swan-Ganz, which measures estimates the left atrial pressure and gives you a definitive right atrial pressure. So exercise stress testing for chronic atrial aortic regurg may be done to assess functional capacity. So that's a possibility for athletes, okay? or we're certainly wanting to, not athletes, but before they start working out. If you got aortic regurg, you're probably not going to be a prime athlete. You're usually older or have a acute issue that's causing the problem. Medicines, what can we do? Really, there's nothing to do for asymptomatic patients. But if you're symptomatic, we can use the same idea that we talked about for other regurgitant murmurs. ACE inhibitors, dihydropyridine, calcium channel blockers, DHPs, hydralazine can be used. And we're going to talk more in detail about that in the heart failure lectures and go in more about these meds. And you're learning about them now. And you're going to add beta blockers for those patients with angina, okay? And certainly those that are not surgical candidates, we've got to treat the angina and prevent that. All right. So the frequency of evaluation of monitoring an outpatient is exactly the same. Every 3 to 5 years for mild, every 1 to 2 years for moderate, and every 6 to 12 months if it's severe. And once again, any change in symptoms, okay? So luckily, these match up pretty well for the frequency of monitoring for the echoes, thank goodness, but you are responsible to know those timings as for your boards. Surgical therapy, it's the only effective therapy for aortic regurg. And in context of this, yeah, the definitive treatment, Jerry, would be transesophageal echo, but initial look would be with the transthoracic. So if I asked you, what's your initial imaging, transthoracic, to definitively diagnose it, transesophageal, yeah. And the annual monitoring would be done with usually a transthoracic. They don't typically do it with the transesophageal. Okay, all right. Now, we always go to the valve replacement if it's acute. That's the #1 priority, all right? Who gets surgery? Those with symptoms and heart failure class greater than 2. So you guys learned this in pathology, stages New York Heart Classification 1 through 4. We're going to get into detail about those stages, and you'll know them cold before the exam, and stages A through C. We'll talk about them in a separate lecture. Ejection fraction less than 50% gets it. They get surgery. And those that need CABG or other cardiac surgery also get the aortic valve fixed if you're in there. You're already there, go ahead and fix it. Prognosis of these patients, they typically do well in the mild to moderate stages, but severe, not so well, especially if they have angina or heart failure symptoms, okay? They don't do well. And the last thing on this, let's check on your learning. All right, you have a 65-year-old man presents to his physician for a gradual decline in exertional fortitude and dyspnea on exertion that has been getting worse over the past 2 months. Physical exam demonstrates a mid-systolic murmur, best heard at the second intercostal space near the right sternal border. The murmur decreases with isometric hand grip and Valsalva maneuvers. What is the most likely diagnosis? What do you guys think? Okay, good. Liking it. Liking what I'm seeing. All right, perfect. Yes. So aortic stenosis, very common, right? 65 years old, getting exertional syncope. It's going to decrease with hand grip. Why? Because the afterload, it's going to put more fluid back into the heart. And so we're going to decrease that murmur. And Valsalva maneuvers are going to decrease it too. Same reason, because you're decreasing. When you increase the pressure, the blood can't get out. It's going to decrease the murmur of the regurgitant portion. So that's why. So it's going to decrease those. Excellent. So this just explains why that's the case for aortic stenosis, okay, and how it came about. And that's your explanation. What are your questions today? We went over all the valves for basically the left-sided valves. We talked about mitral stenosis, mitral regurg, mitral valve prolapse, aortic stenosis, and aortic regurg. And tomorrow we'll be on the right side. We'll go over the right side of the heart and talk about infective endocarditis. Read over chapter 8 on this. This is a good one to read on. These are level 3. The left side of the heart is a level 3. Left side of the heart is a level 3, meaning you need to know everything about these, and as much as you can learn, get after it. You're going to have complex questions about these for the diagnosis and the treatments, because they all tie to heart failure on the left side. So we got to worry about those. And don't get too hung up on when you're talking about the separation of like, oh, I've got acute versus chronic management of those treatments. What you want to know is you refer them for surgical intervention. You don't set on them with meds. That's the idea. Don't get too caught up on that. To verify again, endocarditis is the most common acute cause of aortic regurg if the valve is involved. Yes. And aortic dissection is the most common for aortic root involvement. Yes, ma'am. You are correct. Yep. And so that is the takeaway message. Good. Because if you do have infective endocarditis, the most common valve that's involved is aortic valve, and it's most likely aortic insufficiency. All right. This is a good one to watch the osmosis videos on to see the flow of blood going through them. They're very helpful. I may show a couple tomorrow. And then the pulmonic, the pulmonic and the tricuspid valves, you need to recognize them and understand them, but not in the detail that you need to know for the left side. Left side, you just got to know everything. Yeah, you can use Harris. You do have to pay for osmosis, but a lot of them are free. If you Google, I know the mitral valves and stuff are free. All right, let you guys know if you guys are good to go, and I'll see you guys soon. Amy, go ahead.